about 20 hours of flying. So I should actually be taking a nap about this time. But we have more important things to tend to. Thank you all for being here. So let's try to have a great conference. I was asked to speak about a model for sustainable cardiovascular care delivery in developing countries, especially in the light of a rising global burden of cardiovascular diseases. Over the past several years, we have witnessed an epidemic of cardiovascular diseases across almost all nations of the world. CVD, for short, is the #1 cause of death and disability in almost all 190 or so countries, reporting statistics. So it is imperative that every nation of the world must pay close attention to the CVD epidemic. Otherwise, there will be complete disruption of the social order of things. The civil society as we know it will be grossly affected if we're losing the most productive segments of the society to cardiovascular disease epidemic. Unfortunately, cardiovascular disease strikes people in the most productive years of life, and that disrupts family structures, has very significant impact on the economies, and of course if children that depend on their parents cannot have those parents, if parents die young, then you have a cycle of poverty that ensue. And so it's not surprising that WHO has recognized, and when we talk about non-communicable diseases, which the main bulk of non-communicable diseases will be from cancer and cardiovascular disease. And of course you have respiratory ailments and other things in there. But as a group, non-communicable diseases are very significant and have a very significant impact on life in all countries of the world reporting. It's been recognized by WHO as the major challenge to development in the 21st century. And if you go back and look at the work of people like Hans Rosling, we begin to understand the intersection between healthcare and development. It is impossible to have development without addressing the health indices of a population. So as we begin to look at this epidemic in developing countries, we recognize the epidemiologic transition that is going on. Over the past decades, there has been a lot of focus on communicable diseases and diseases of malnutrition and the likes as being the predominant problem in developing countries of the world. We tend to kind of have a kind of binary classification of looking at diseases of affluence and diseases of poverty. But there is a complete convergence of the two. So in developing countries of the world, we're still battling, as it were, diseases of poverty, which will be the communicable diseases and the diseases of malnutrition, but we are now confronted with the imagined epidemic of diseases of affluence. So you have double burden of disease in developing countries. And I will even extend it by saying this is even compounded by poor governance and weak institutions and weak systems. So you might actually like to think of it as a triple burden of disease. So you have diseases of malnutrition and not communicable diseases, what Professor Elder just spoke about with vector-borne illnesses, and then with westernization of societies, indigenous cultures are giving way to Western cultures, dietary patterns are changing, we have fast food all over the place, people are not farming as much, there's migration to the cities, people sit in traffic all day long, there is no exercise going on. Everybody is looking for an air condition, so we probably will get to where everyone will carry an AC in their pocket so that we don't have to do anything. So you have these situations that provide the complete setup for those triggers that lead to those non-communicable diseases we talk about. And this is the kind of situation you find in many developing countries. And the work we do actually has allowed us to look at this in a different context, because when we talk about developing countries, we tend to refer to low-resource countries or the poorer countries of the world. But I will challenge you to look at this matter in a different way, because within countries, you have pockets of poverty. You have pockets of affluence. So even in the richest countries of the world, the same problems that you have in the developing low-resource nations exist in all the rich countries of the world. They just happen to occur in the low-resource neighborhoods. And so whatever we're going to talk about here, you can extrapolate it to all countries, except that in some countries it's much larger spectrum, and in some, even in the United States, you have areas that are low-resource areas that have the same problems that you have in the countries that are low-resource environments. So non-communicable diseases, as I had mentioned before, constitute the bulk of it. It's cardiovascular disease and cancer, or minor part of it will be respiratory illnesses. But if you look at the major part of it, of all causes of the global disease burden, the majority of it will come from the illnesses associated with cardiovascular diseases or cancer. And then if you look at all the deaths occurring around the world, then you find that non-communicable diseases constitute the bulk of it, because of all about 58 million deaths annually around the world, about 2/3 of that will be from non-communicable diseases. And this is where it gets very interesting. About 80% of those deaths occur in developing countries. When we think about it, we've been told in all the press, it's always about, think about developing countries, think about malaria, think about tuberculosis, think about HIV, but don't bother to think about cancer and CVD. Well, that's pure fallacy, because the reality of it is that 80% of the global death from non-communicable diseases occur in developing countries. So you have 35 million deaths every year, which is about 60 to 70% of the total global deaths are from non-communicable diseases. But of that 35 million, 28 million, that is 80%, occur in developing countries. And as we go further into the talk, you will keep in mind this 80%. You will understand how important it is. What that means is that 20% of deaths from non-communicable diseases occur in the developed countries of the world. As we go further, you will see where 80% of the resources are. And then they'll see the dichotomy. And that is why we have the problem that we have today. But what is also very shocking is that of the 28 million people that die in developing countries every year from non-communicable diseases, 50% of those are preventable. What it means is that if we will do the right things and put the right systems and infrastructure in place and the right human capital, possibly 40 million people that die every year will not die. The World Health Organization Global Status Report on Non-Communicable Diseases in 2010 showed exactly the same pattern again, that almost 50% of deaths resulting from non-communicable diseases in people before the age of 70 occur secondary to cardiovascular diseases. And now, where are these deaths happening? If you look at the graphics here, to buttress what we have just talked about, this is what is happening in lower middle income countries. This, from here to there, are deaths resulting from non-communicable diseases. These are deaths from communicable diseases. In all areas of the world reporting, the number of people dying from communicable diseases have been shrinking, but the number of people dying from non-communicable diseases have been expanding. If you look at the lower middle income countries of the world, compared to the most advanced economies, this is the high income country. So you see about 4 million people dying every year, and then here are 4 million females, and then you have about 8 to 12 million here, and about 8 to 10 million men dying from non-communicable diseases, and most of those are occurring in the developing countries of the world. The only place that is still, and this is from 2010, this global status report, and the African region, you still have more people from communicable diseases, but the projection is that by 2025, this will be completely different picture. So by 2025, it is expected that across the world, all the deaths that will occur, the majority will be from non-communicable diseases. And the majority of those deaths will be occurring in the developing countries of the world. CVD will account for 17 million deaths annually. And this will be about 30% of the entire global deaths of the 58 million people that will die annually, and will constitute about 50% of the deaths from non-communicable diseases. 32 million people will suffer from heart attack and strokes yearly. 85% of the global mortality and disease burden for CVD, again, will be seen in the developing countries of the world. And yet, the resources for managing these illnesses, 80% of those resources reside in the most developed societies. Even within countries, in these developing countries of the world where we have limited resources, the few resources that exist are dedicated to the most affluent of the population. And so you have a situation where those who need help are the ones that are denied of the help they need. In order to address this problem, we must understand what the drivers are. So the typical, everybody, we can recite this in medical school, everyone is taught about the same diabetes, hypertension, smoking, obesity, lack of exercise, high cholesterol, genetics, diet, age, and gender. As you get older, you're more at risk, right? But as one of my colleagues in my days at Vanderbilt used to remind me that, you can never outrun your gene pool. So genetics remain a very important part of the story. That's why you're going to have individuals that will do everything right and still suffer from premature cardiovascular disease. And that is why, this is the strongest argument you will make to people who tell you that if you can only focus on prevention, then you don't have to worry about these things. Prevention is important, but therapeutics remain important as well, because no amount of prevention will eradicate the problem, because there are individuals whose genetic makeup will always put them at risk. And that is why every society, every country, developed or undeveloped, must begin to work towards building the ecosystem that will make sure that when that cardiovascular disease strikes, there is something within the country to address the problem for the individuals. Well, of those drivers, there are some that are more problematic than others because of their impact. on society. And diabetes happens to be one of them. It's a worldwide epidemic, and is an epidemic that has been rising in prevalence over the years. This is again from the International Diabetes Federation, looking at global burden of diabetes. In 2011 to 2030, the projection is that the global prevalence of diabetes will go from 8.3% to 9.9%. That is a 20% jump in prevalence from 2011 to 2030. Now, this is an average of the global picture. But there are certain countries where that prevalence inches closer to 20%. If you look at countries like Trinidad, Suriname, Mauritius, all of those countries have much higher prevalence, and much of the Pacific Island nations, the prevalence of diabetes is much more than this 8.3%. But if you're looking at the global picture, you'll see that when you have a 20% rise in prevalence from 8.3 to 9.9%, that translates to a 50% increase in the number of people with diabetes. That will be 366 million to 552 million. That is about 186 million more people will have diabetes by 2030. And that is quite significant, because in cardiology we have recognized that diabetes is a heart disease equivalent. You know, you manage a diabetic patient as if they already have heart disease, because we know that with time the vessels will become atherogenic and the persons will be at risk for a myocardial infarction. And those are also people who have higher risk of silent myocardial infarction. You know, they have a heart attack and they don't even know it until they start developing symptoms of heart failure and other things. So it's very important subject for practicing cardiologists. And so when we start having a rising prevalence of diabetes, it is a kind of an early picture of what you're going to get with cardiovascular diseases, because as diabetes begins to increase, then you're likely going to have an increase in CVD. Hypertension is also another factor. There is a rising prevalence of hypertension globally. In much of Africa, hypertension is a problem. In Tanzania, you have 30% prevalence of hypertension, which is a figure that is also seen in many African countries. There's a recent publication just last week in a journal that looked at hypertension in African Americans, suggesting that as many as 75% of African Americans over the age of 55 already have hypertension. And again, that suggests that there is a predisposition for Black people to be more at risk for hypertension, and that could also be a factor of genetics and epigenetics and all those interplays that could lead to hypertension. Of course, we know that Black individuals tend to have more salt-sensitive hypertension variants, and then there is also higher vascular reactivity among Black individuals, and those are the things that can put people at risk for hypertension. Now, tobacco use is another problem, and that's one of the things that, in public health, we tend to pay close attention to tobacco as well as other high salt content processed foods. But the problem is that the emphasis, the public sector, the public policy that addresses these things tend to occur more in the developed countries of the world. And what has happened is that the tobacco industry have moved their marketing to the societies where the institutions are weaker, and they're advertising heavily. And so we have a rising prevalence of tobacco use in those countries. And that is why Africa as a continent has the highest the highest increase in tobacco use. In some countries in Africa, rising by about as much as 4 to 6% per year, more people smoking. While in the West, in Nashville, Tennessee, you almost have to force yourself to smoke because you wouldn't find any place that makes it conducive for you to smoke. Every restaurant is a smoke-free environment, right? But you go to certain countries and you have concerts where 12-year-olds are being handed over cigarettes by the tobacco industry. And what is going to happen as those people continue to smoke and they become addicted to tobacco, and then they're gaining weight at the same time and they're getting diabetes and tobacco use is increasing, then of course the epidemic will rise. And that takes us to obesity, which is another worldwide 8 million deaths annually around the world. About 2/3 of that will be from non-communicable diseases. And this is where it gets very interesting. About 80% of those deaths occur in developing countries. When we think about it, we've been told in all the press, it's always about, death from non-communicable diseases occur in developing countries. So you have 35 million deaths every year, which is about 60 to 70% of the total global deaths are from non-communicable diseases. But of that 35 million, 28 million, that is 80%, occur in developing countries. And as we go further, deaths from non-communicable diseases occur in the developed countries of the world. As we go further, you will see where 80% of the resources are. And then they see the dichotomy. And that is perceptions about technology. And I think much of these misconceptions come from multilateral agencies in the way they have approached healthcare in developing countries and low-resource environments. Multilateral agencies are apt to want to focus on the same communicable diseases, which are important, but they cannot solve the problem if that's all the focus that we have. We're talking about an epidemiologic transition where nations are having a rising prevalence of non-communicable diseases, and yet our focus remains on communicable diseases only. Sometimes, there is a little bit of, I don't know a polite way to say it, it's a little bit of condescension in that attitude where somebody says to you, one thing is good enough for you. Okay, tell me when you have malaria, but don't call me if you're having a heart attack. You're not sophisticated enough for that, right? But we must reject that notion that says that, technology is not good for some people, but it's good for others, and that's what leads to the misconceptions. This slide is here as an illustrative. I hope most people in this room are old enough to know what this is. Does anybody remember this? All right. I know Professor Elder probably doesn't. He's too young for that. But if you remember this, I'm sure you remember that. Everybody's walking around now with maybe one or two of this in their pocket. Now think about how you will feel if somebody told you, don't even bother with this, continue with that. And when we're told that certain types of technology are just too sophisticated for certain locations, that is exactly the message that is being sent. The same way we can leapfrog. In any country in the world now, if you don't have landlines as a country because you were not wealthy enough to build the infrastructure for land telephone lines, it will be stupid to start building landlines in 2018. You don't need it. You now have an opportunity to leapfrog because the technology has moved on. Some people may not even be familiar with this, right? For those who write letters, I just flew in from the United States today. Since I got here, I have been in contact with my office by WhatsApp, and we even talked on the phone through the WhatsApp calling. Maybe 30, 40 years ago, they will have to wait 3 weeks for me to send a letter that I've arrived. But not anymore, right? This is Twitter, Facebook. You know, I'm sure this conference is on Twitter. People are commenting about the conference. It's posted on Facebook. It's possibly on Instagram. And somebody in Ethiopia is looking and seeing what is going on in Bangkok. If we can use all these technologies to break down barriers in everything else, why then are we reluctant to break down the barriers in healthcare using the same technology? There is no reason why we shouldn't. With these technology that we know now, we believe that we can break down barriers across the world and distribute healthcare, high-quality healthcare, to everyone. The myth about healthcare, technology in healthcare, the myth about technology in healthcare is all it is. It's a myth. We've had all kinds of things, you know, healthcare. We've had all kinds of things telling us that it increases healthcare costs, widens inequalities, reduces access, does not improve quality of care, unaffordable. All that is not true. There is no data to support all of that, any of that. In fact, the data is opposite of that. Technology improves healthcare, it's cost effective, it improves access, it improves workflow efficiency, it improves patient information management, reliability, it makes it safer. When I was a resident in New York, we used to write prescriptions. You know, sometimes you will write a prescription, your writing is awful. Somebody takes it to the pharmacy reads it the wrong way, doses out the wrong thing, and all kinds of complications set in. Now I can go on the electronic medical record system. If I put digoxin, if I'm writing, maybe I'm sleep deprived overnight, I might write digoxin 25 milligrams, which can kill as many people as possible, which is wrong. I'm meant to write 0.25 milligram. Now, if I go on electronic medical records, I wouldn't have that option. You click down digoxin, it will only give you 0.125 or 0.25. That is safer. So it's not relying, and if I write the wrong thing, even if I free text it, artificial intelligence built into the systems will ask you, are you sure? Is this what you want to do? And when you send it through, something else will pick it up. So it really makes life a lot easier for everyone. But for me, one of the most important aspects of technology is being able, the ability to break down barriers completely, the ability to distribute healthcare to people in rural settings without, there are certain things you cannot multiply. If there is a pediatric oncologist in one city, perhaps you're not going to be able to get that pediatric oncologist in another city that is remote. Perhaps if you put him there, you can't afford to pay his salary. But he can stay right here in Bangkok and get all the information and provide an opinion that could save a kid's life. And the same is applicable in so many ways. And that's the model that we use to develop our programs. And I'm going to give you some examples of what we do with two case studies from our programs. The Heart Institute of the Caribbean in Jamaica and Docs Heart Center in Enugu in Southeast Nigeria. We arrived in Jamaica in 2005. Jamaica, like any other country, has a very high prevalence of cardiovascular disease. It's the #1 cause of death and disability in Jamaica. In fact, nearly 60% of hospital admissions in Jamaica are related to cardiovascular Diseases. But at the time that we started our program there, access to cardiovascular care was very limited. There were very few cardiologists. There were no cardiovascular techs. If you needed to do an echocardiogram, you had to wait a couple of months to get an appointment. And then when you get the appointment, it will depend on whether the doctor is available or not to do that. So in order to solve that problem, we needed to build a program that used technology to resolve some of these problems. And this is our facility in Jamaica. It's built on a model that believed that smart and efficient use of technology could be cost effective, and we can leverage technology to improve access, quality, and affordability. And from the beginning, we had a strong emphasis on training, research, development, and innovation. We knew it had to be run as a strong, based on strong fundamentals, recognizing it's a private sector-driven initiative. But because we wanted to make sure that everyone is covered, we introduced what we call an open access to care model. And that open access to care meant that anyone that needed attention will not be turned away just because of their inability to pay. Now, the only way to fund that will be through a cross-subsidization model, which means that those people who can afford to pay will have to pay the full price to give cushion to accommodate those who cannot afford to pay the full price. And that has worked very effectively over the years. And these are some of our staff at work. And this is one of my most brilliant interventional cardiologists. And you guys took him from me. He's now in Thailand. So we lost him to Thailand. But so we set up a program that made it possible with a fleet of cardiac ambulance services that can go in and pick people on demand. There's our emergency room specific for cardiac. These were things that were thought not to be possible. In fact, we're encouraged that it was not possible. Before we set up our program, those who had the resources had to go to Miami, somewhere in Florida, to pay, which again is one of those disjointed ways where you have the poorest countries of the world subsidizing the richest countries of the world, because when they go to Miami, they don't have Obamacare, they don't have Medicare, they're going to pay full price, right? But they can pay a fraction and get it at home in Jamaica. So we run a program that is based a lot on technology. We use electronic medical records. We make sure that our patients have access to doctors on demand. They can get appointments, same-day appointment. We have telemedicine infrastructure. We communicate with doctors around the world so that we get expertise from anyone that we need. Even my doctor that is here in Thailand still participates remotely by giving an opinion. And we have been able to do these things at a fraction of the cost that is done in the United States, Canada, or UK, and has brought the what we believe to be comparable quality of cardiovascular care to the Caribbean. And it's this model that we're now expanding and showing that even within countries, even in the most affluent countries of the world, there are pockets of places where there is a lot of deficit, and those are the places where the disease burden is highest. Those places are places that can benefit from the model that we use. And you can do this effectively by use of telemedicine to bridge access to care, using universal medical expertise from anywhere in the world that you can find it. We set up our systems. Things can go to a cloud server, and experts from around the world can log in and give an opinion with an encrypted password. And it's pretty safe, works very well. This is our telemedicine infrastructure, how we distribute information to various providers. And then they can log into the system and look at studies and then render an opinion. And the same model works effectively in virtually every location because the technology is there. It's just about harnessing that technology and putting it to work for healthcare, just the same way that it's been done for all other areas of human endeavor. And we've taken the same model and we've launched the Doc's Heart Center in Enugu, Nigeria, and we're looking forward to implementing a robust telemedicine platform there where individuals can get opinion from specialists from around the world without stepping outside of their homes. And we can access doctors using the web, using the remote desktop, and even on your cell phones, people can access doctors now. There are actually, Malaysia has a Doc2U that I'm sure some people from Malaysia here are familiar with. It's a cell phone. You can do consultations with your doctor and all that. These things are much more useful for those people who have limited access to care. And with that, we can make healthcare more equitable around the world. And I believe that the model that we've pioneered seems to work quite well, and I think is a model that can work for many countries and within countries. And I thank you for your time.